hope you're not hungry. So just 30 minutes more, okay? I'm going to talk something about menopause and mental health. So this is the introduction slide. I think it's common for every presenter now. It is a cessation of ovulation due to depletion of responsive ovarian oocytes. Generally occurs between 47 to 53 years. This is a worldwide data. As ma'am said, that for India, the average age is around 46 years. The menopausal stage is characterized by increase in FSH and LH, whereas there is reduction in estradiol, progesterone, and inhibin. We'll come back to this. This was again showed by ma'am. The erratic and fluctuating levels of estradiol and progesterone observed during the menopausal transition as early as stage 3, which is seen here. Stage 3 is here, that is before the menopausal transition. So the psychiatric symptoms, along with hot flashes, night sweats, sleep disturbance, irritability, insomnia, breast tenderness, migraines, joint pain, all start in this phase. That is just before the menopausal transition phase. The stage 1 and beyond, which is the post-menopausal phase here. This is a stage where due to sustained low estrogen, there is vaginal atrophy, urinary incontinence, and sexual dysfunction. So what we have observed is the psychiatric symptoms, most of them present during the menopausal transition phase rather than the post-menopausal phase. So midlife is a transition time, and stressful life events from divorce to a second career combined with physical changes can be overwhelming for a lot of women. Menopause significantly impacts mood as well as mental health. It has higher stress levels. There may be depression, anxiety, panic attacks. There may be physical symptoms such as sleeplessness affecting the biological functioning. Also seen that schizophrenic women, that is women who have had schizophrenia before, the usual incidence of schizophrenia starts at around 20 to 30 years of age. So those have an increased risk of an episode of schizophrenia as their production of estrogen decreases. So the take-home message here is to encourage all women to talk about mental well-being and seek the right support and help. It is not only the gynecological features which are hampering the females, it is also the mental health features which are often undiagnosed and which needs to be talked about. So women with previous hormone-related issues such as postnatal depression or postpartum depression, as we all know, or PMS or PMDD, they also have a high risk of developing issues around the menopause. So these are the symptoms of menopause. I don't think any other condition has these many symptoms compared to menopause. So nearly most of the symptoms are covered by ma'am also. I'm going to focus on the mental symptoms. So you can see the most common symptom as for psychiatric symptoms are brain fog, difficulty concentrating, there may be mood swings, irritability, anxiety, depression, night sweats, which again lead to insomnia. There may be digestive problems, bloating, loss of libido. So I'm sure most of the household having menopausal or perimenopausal woman would have this scenario at night. I know I don't want to, it's doctor-patient confidentiality, so I won't emphasize. The symptoms, as we mentioned earlier, there are irregular periods, absent periods or heavy bleeding, there may be hot flushes, night sweats, tiredness, mood changes, irritability, anxiety, poor self-esteem, vaginal dryness, decreased sex drive, poor sleeping, bladder issues, vaginal problems, changes in skin and hair, joint pains, bloating, and long-term problems due to low estrogen, as ma'am already said, it is osteoporosis, increase in cardiovascular diseases. So as psychiatrists, we always try to look at the context of life in every illness which is presented to us. It's very easy for us to label everything on menopause if we have a perimenopausal woman coming with depressive symptoms or anxious symptoms. But there is more to it than just menopause, and we need to look into it a lot more. So At menopause, the women would have a sense that they are starting to age, beginning of aging. There might be some changes in physical appearance. They may have some minor health problems arising. Children may be leaving home. They may be planning to retire, which may again affect their economical issues. Some of the women might be in a sandwich generation, which is now very prevalent as the marriages are getting late. That is, they are responsible simultaneously for child rearing as well as caring for aging parents as well. There may be some ill health for the spouses, friends or relatives. There might be marked decrease in standard of living due to loss of job. There may be body image concerns, new wrinkles, abdominal obesity, fitness may decline, arthritis. There may be changes in sexuality as well, that is reduced libido, thinning and drying of vaginal lining. There may be early signs of forgetfulness, which she might be scared that she might be going into dementia. So the woman's experience of menopause is not only the biological changes due to hormones, it also is shaped by the psychological, social and cultural context in which she lives. The risk factors here are low income, unemployment, restricted education, discrimination, violence. All these leads to a reduced ability to cope with life issues. Coping is a very important thing here because every woman goes through menopause, but not everyone develops psychiatric illness. So the thing which differentiates them is the ability to cope with the life issues. So if there is a reduced ability, it is an important risk factor for mental health issues. So now, if a woman comes to you perimenopausal or menopausal, how do with the complaints you have, you feel she is depressed, you feel she is sad, low mood, crying. How do you differentiate that she is depressed versus it is only emotions related to life goals? She may have some stressors due to which she is stressed about. So there are some fundamentals which say this is a depression and this is not just only emotion with respect to life changes. So the clinical symptoms of depression, that is low mood lasting 2 weeks or more. If it is 2 weeks or more, it is persistent and that indicates she is depressed and it is not just a transition. Feeling hopeless or flat. Flat affect is a particular thing which is only seen in depression. Flat affect is something, even if you are sad, even if there is something wrong going in your life, there is, if you see something amusing, something that makes you happy, you might get happy for a short amount of time. It's not that you are happy continuously, just you feel amused, you feel happy. But in case of flat affect, there is no response to even a good cheerful stimuli. If you are flat affect means if you are depressed and anything happy goes around you, you just can't feel it. You are depressed continuously. So that indicates flat affect and it indicates a depressive disorder, not only a change in emotion. Also feeling tired continuously, changes in appetite, feeling worthless, changed or troubled sleep patterns, feeling of dread, unease or agitation, trouble concentrating or making decisions, thoughts of harming herself or death. So whenever the thoughts of self-harm or death arise, it's always termed as depression, not an adjustment issue. And also advised to seek care as early as possible in that case. So now we will see the effect of the reproductive hormones on CNS during menopause. That is why the lack of estrogen or progesterone is causing all these psychiatric symptoms in a patient. So estrogen, as we know, the receptors are particularly active in brain, in medial amygdala, hippocampus, limbic systems. All these three, the medial amygdala, hippocampus as well as the limbic systems, are predominant in emotions. They all manage the emotions of our body. So the estrogen here, it acts as an agonist on serotonergic activity. So what it does is, it increases the number of serotonergic receptors, it increases the uptake of the neurotransmitter as well as it increases the synthesis of serotonin. So obviously if this is going to go down, the agonist effect is also going to go down. And as we all know, serotonin is a happy hormone. So when this goes down, there is going to be some amount of low mood and sadness. Progesterone receptors are also seen in the brain, in the limbic system as well as hypothalamus. Here Progesterone is an hypnotic as well as anxiolytic. So women having sleep insomnia issues, they may be due to the depletion of progesterone. Progesterone also seems to have some negative effect on mood, which is dysphoria and irritability, which is what we see is in PMS, where there is when a lady is near menstruation, there is dysphoria, irritability because of high amount of progesterone at the end of the luteal phase. Also, the plasma testosterone levels correlate with women's sexual drive. The lower testosterone levels during menopause causes lack of sexual desire as well as interest. The DHEA and DHEAS, they have a positive effect on mood. Higher levels may be less likely to experience depressive symptoms. So now we'll talk about depression. Initially, it was thought that perimenopausal woman, there is nothing called as depression. It's only an emptiness syndrome. That is, घरમાંથી છોકરાઓ બહાર જતા રહ્યા, મમ્મી પપ્પા એકલા થઈ ગયા, and that is emptiness syndrome. But now it has been turned into involutional melancholia. So the emptiness syndrome, it is a thing, but not necessarily everyone going through this is just emptiness syndrome patient. It's depression. It can be depression. So the new onset depression is seen in 20-30% of women during the menopausal transition. There's a high number of depressed patients. So around 100% of perimenopausal women, 20-30% may have some depressive symptoms. There is 2 to 4-fold increased risk of depressive symptoms and 2-fold increased risk of depressive disorder. So symptoms may be 2 to 4-fold increased, but the entire syndrome, the depressive syndrome, clinical depression, what we call, is different from just the depressive symptoms. So symptoms might be more common compared to the entire disorder. So that is seen that 2 to 4-fold increase in depressive symptoms and 2-fold increase in depressive disorder in a medically and reproductively healthy women without a prior history of major depressive disorder. The strongest risk factor seen here is higher variability of between visit estradiol concentrations in women related to their non-depressed premenopausal baseline. So before the menopause, the greater the decrease in estradiol concentration, the greater the risk for developing depressive disorder. Other risk factors did include personal history of a mood disorder, previous reproductive related mood disturbance, as we talked about it earlier, PMS or PMDD, or postpartum depression, psychological stresses. Also, hot flashes here were 1.3 to 2.2 folds more likely, which again indicates either the hot flashes can cause depression, or there might be the same etiology for both of them, that is hot flashes as well as depression. There might be a psychosocial influences, as we saw here. The psychosocial stresses can cause depression. The psychosocial stresses include a prior depression, negative attitude to menopause and aging, increased stress and daily hassles, experience of more severe menopause symptoms, physical inactivity, smoking, dissatisfaction with relationships or no partner, and low socioeconomic class or unemployment. So these are the most common symptoms in a depressed women in this age. It includes fatigue, lack of energy, slowed cognitive function, કશું યાદ ન રહેતું એવું લાગે કે ભૂલી જવાય છે, feel like they're aging, inattentiveness, a lack of interest in one's enjoyable activities, feelings of worthlessness, hopelessness and helplessness, suicidal thoughts or death wishes, mood swings. The death wishes here, it is not important કે મારે મરી જવું છે, it's also મરી જાઉં તો સારું રહેશે મને. That is also considered as an important finding in depression. It's not always a suicidal ideation with a plan or saying, "Okay, I'm going to die." It's better if I die is also a red sign or a red flag and needs to be treated immediately. Mood swings, irritability, crying for no reason or tearfulness, heightened anxiety, profound despair, sleep problems related to hot flashes or night sweats. So, for management of depression in perimenopausal or menopausal women, we need to take a multidimensional approach. We can prescribe antidepressants, escitalopram, venlafaxine, duloxetine, We have seen the venlafaxine, duloxetine. There are types of SNRI, which is serotonin and norepinephrine reuptake inhibitors, and they work better in menopausal or perimenopausal women because they also concurrently they improve the distress tolerance of hot flashes. Also, hormone replacement or estrogen therapy can also be used in severe cases. The cognitive behavioral therapy is a new kind of therapy coming up right now. Lot of psychotherapists as well as psychiatrists are practicing that, and it has a good response in case of mild to moderate depression. In patients we feel who do not require, they are not so severe to require pharmacotherapy, we can go for cognitive behavioral therapy. They help in correcting cognitive distortions as well as enhancing coping mechanisms, which is again important to mental health. Physical exercise is one of the most important and very easily available treatment for depression. Outdoor walking, running, cycling, swimming, very important. I don't think there are any side effects of that unless if you crash with somebody. You need to maintain a diary. Sometimes what happens is due to some stressors we get sad, we get low, and we feel it is depression. So if we maintain a diary, we can just correlate. If this is not a depression, this is not going on throughout the day, this is only a reaction to some emotional stimuli which I had earlier. So maintaining a diary is very important in this case. Some antioxidants with vitamin E, phytoestrogens, vitamin C, aspirin, folate, vitamin D, calcium can also be given. There is a herbal supplement which we sometimes prescribe, ginkgo biloba. It has some antidepressant property as well as some good effects on cognition. So we can prescribe it. It is very safe. We have given in a lot of patients and good results have been seen. Melatonin for patients who are having insomnia along with depression, we can prescribe. Now anxiety, I am sure most of you here have experienced anxiety some or the other time, but that is not pathological anxiety. When is it pathological? It is when it is intense over an extended period of time and it interferes with daily life. Then we can call it a pathological anxiety. So the symptoms here in a menopausal or perimenopausal woman is racing heart, heaviness in chest, rapid breathing, sweating, hot flushes, shaking, dizziness, nausea. So as you can see, these symptoms are very similar to the postmenopausal symptoms or perimenopausal symptoms. So sometimes it is very difficult to differentiate if a woman is really having anxiety or it is just postmenopausal symptoms. So it is also the hormone replacement therapy has been seen to lower the scores on anxiety measures as well. So anxiety is linked to severity of menopausal symptoms experienced. If a woman who is a known case of anxiety disorder in menopause not treated has been seen to have greater menopausal symptoms compared to those who are not anxious. So it seems it has a similar psychopathology to depression, and it is influenced by prior history of anxiety disorder, psychosocial factors such as relationship status, family problems, socio-economic status, and lifestyle factors like exercise and diet. So how would we manage the anxiety? Firstly, we need to determine the severity of anxiety symptoms. Why? So based on the severity, we can go for the appropriate management required. I don't think for mild or moderate anxiety, we don't need antidepressants, anti-anxiety medications. Cognitive behavioral therapy, lifestyle modifications are more than enough for perimenopausal women who are again also taking HRT, which will cure most of the symptoms as well. Diary again is an excellent tool for establishing the true nature of anxiety. Again, what stressors sometimes patient has, and that can cause anxiety, and then she will be labeled as anxious or anxiety disorder is not the case. We need to be a proper, there needs to be a proper charting of anxiety, where are the symptoms occurring, what is the reason, how are they going on. Physical exercise again is a good treatment for anxiety. HRT may also lower anxiety levels, decreasing the severity of menopausal symptoms such as hot flashes, improving overall well-being. Psychological management, relaxation techniques, breathing exercises, CBT again here helps in anxiety, low mood, and insomnia. In severe, moderate to severe or severe anxiety, we prescribe SSRIs or SNRIs. Escitalopram, we have seen sertraline to be the most efficacious in case of anxious symptoms in such patients. And it is also the most cardioprotective antidepressant out of all, so it is very favorable in case of anxious women in such age. Short term, we can prescribe benzodiazepines, clonazepam, lorazepam, alprazolam, whatever, any choices preferred. Prefer lorazepam, alprazolam low because it is a shorter acting and does not cause sedation the entire day. I think clonazepam, diazepam can cause some morning sedation or afternoon sedation if given at night. So prefer lorazepam and alprazolam whenever possible. So anxiety, depression, and sleep. Most of the anxious and depressed patients have sleep disturbance as a complaint. So all anxiety, depression, and sleep are interlinked. Lack of sleep can affect the mental health, cognitive function, and cardiac health as well. Sleep disturbances are common throughout the perimenopause, menopause, as well as post-menopause. So what is the sleep disturbance? It can include difficulty getting to sleep, that is initiating sleep, difficulty staying asleep, that is maintaining sleep, poor quality sleep, waking up early, someone sleeps at 9, 10, wakes up at 2 and then cannot get to sleep back, fatigue during the day, all these are included in sleep disturbance. It is seems to be caused by lack of estrogen, causing hot flush, sweats, bladder problems, joint aches and pains. Progesterone, as we described earlier, progesterone is an anxiolytic as well as a hypnotic. Reduced progesterone during menopause or post-menopause can have an effect in sleep disturbance as well. Melatonin also, it decreases with age, influenced by estrogen and progesterone levels. Management of sleep disturbance. Firstly, adequate exercise is an important. If you are not tired at the end of the day, I don't think you are going to sleep. That is what we feel. You need to be working. You need to do at least a light exercise, not just before bed. It's important to have an exercise at night. You can have a light walk. Should not be a strenuous exercise, but at least walking 35 to 40 minutes a day is a good exercise for menopausal, postmenopausal women. Maintain a regular bedtime and try not to nap in the day. Cognitive behavioral therapy here again can help in menopausal symptoms as well as sleep disturbance. Sleep hygiene interventions can help, as well as if the patient is having some underlying cause like anxiety, depression, we can treat that. If the cause of insomnia is hot flushes, sweat, then we can give HRT. Melatonin can also be prescribed, available in 3 milligrams, 5 milligrams and 10 milligrams dose. Benzodiazepine again we can use. There are newer hypnotics like zolpidem, lemborexant. I hope everyone knows about melatonin. There is a similar substance in our brain called as orexin. So as melatonin is a sleep-inducing hormone, orexin is a wake-promoting hormone, and it acts on orexin receptors in the brain, causing wakefulness. The lemborexant here, it's a new hypnotic which acts as an antagonist against the orexin, thus reducing the wake-promoting effects of it and causing sleep. And if there is concurrent depression, there are some sedative depressives, that is mirtazapine, trazodone. Most of the antidepressants are activating, escitalopram, sertraline, thus we are prescribing it during the day. But these two have good sedative properties and can be prescribed in patients who have concurrent depression as well. Now menopause and psychosis. As such, new onset psychotic disorders are not very common during menopause. It does have an association with low estrogen, with an increase in psychotic symptoms. Late onset schizophrenia, which is after 45 years of age. The usual onset, which we call early onset schizophrenia, is between 20 to 30 years of age. That is the usual age of onset of schizophrenia. But the late onset schizophrenia is more common in women than in men, which again supports the estrogen protection hypothesis. Psychotic symptoms tend to be low during pregnancy when estrogen levels are again high. Women respond better to men to antipsychotic medication, and women of childbearing age tend to respond better than older postmenopausal women. Severe symptom, if there is late onset schizophrenia, has a severe symptomatology and course compared to early onset schizophrenia. More rapid symptom improvement in women who receive estrogen augmentation along with antipsychotic medications. So that needs to be taken care of. We can treat patients with second generation antipsychotics, olanzapine, risperidone, aripiprazole. These are the newer antipsychotics. These are preferred because of better side effect profile compared to the older first generation antipsychotics like haloperidol, trifluperazine. So in such patients, we need to prefer second generation antipsychotics. So sex is one of the most neglected topic in case of post-menopausal women. Whenever we interview them in our consulting, some of them or most of them do believe that menopause is the end of sexual intercourse period. They're not supposed to have sex, or it's not okay to have sex. So this is a clear taboo which is going on in rural areas. I don't know from where did they get this, but certainly that is not the case. There is painful or uncomfortable sex due to reduced vaginal secretions, thinning of vagina, loss of libido, lower sex drive, mood swings and hot flushes, urogenital aging symptoms like incontinence problems, vulval irritation, itching, higher incidence of candida albicans, bacterial vaginosis, body changes that lower self-esteem such as thinning hair, breast changes. So what can we do? There is no as such psychiatric treatment for sexual loss of libido or lower sex drive in such patients. We can again prescribe HRT. Lubricants and moisturizers can help. Vaginal estrogen creams can help with the dryness of vaginal skin. Avoid vaginal deodorants or tight restricted clothing which can exacerbate the vaginal dryness and bacterial vaginosis. Promote continence by encouraging pelvic floor exercises. Sometimes you can prescribe testosterone, not people don't actually prescribe testosterone, we just refer them to gynae. So hot flashes seems to be one of the most common symptom by any women going menopause or perimenopause. There are common symptoms other than hot flashes include night sweats, feelings of fainting, palpitations, dizziness. Here a woman is sitting in front of a psychiatrist saying it and blaming it on global warming. So as my father said, she should not be blaming it on global warming, she should be blaming it on her husband.
Like always.
So severe vasomotor symptoms disrupt sleep and can be distracting and a source of embarrassment during waking up. The reason for this seems to be changes in the thermoregulatory set points located in the anterior portion of the hypothalamus, which occurs. A small increase in core body temperature also precipitates a hot flash in symptomatic women. So sweating, which is profuse at the start of a hot flash, heart rate, skin blood flow, temperature increase, lasts from several seconds to a few minutes. It can be triggered by stress, heat, exercise, hot drinks, caffeine or alcohol. Insomnia caused by hot flashes is one of the primary reasons women seek medical care. Estrogen therapy rapidly reduces the frequency and severity of hot flashes, improves sleep and may reduce the frequency of other perimenopausal symptoms such as joint stiffness and aches, fatigue and transient memory disturbance. So as women do get older, they experience a lot of body changes along with mental changes as well, which includes irregular menstrual bleeding, intramenstrual spotting, menstrual period excessive and prolonged, breast tissue undergoes involution, less glandular, less dense, more fatty, less firmness in breast, may cause sagging, or a change in shape, intermittent breast tenderness, skin changes in collagen layer causing more wrinkling, thinning of skin, atrophy of the vaginal mucosa, less lubrication, discomfort during intercourse, thinning of urethral and bladder lining causing lower urinary tract infections, cognitive and affective symptoms. This all can be managed by, as sir initially said, low dose HRT or MHT as they call it right now, and some psychotherapy may also help. So, what should we take care of during menopause? Firstly, we need to understand it's a transition to the next phase of life. It is a possibility to refocus on growth and reconsider priorities. You can keep something else as your priority because the entire life you have been working, taking care of your children, and now it's time that you focus on your hobbies, reconsider your priorities. Some women experience minimal symptoms and medical intervention is not needed. The experience of menopause is across the spectrum. It differs, it varies across cultures. Some cultures celebrate the menopause as an achievement of wisdom and aging, while some portray it as negative with a stigma around menopause and women's experience. They feel like it's a series of loss of feminine, it's less beautiful, less sexual, less worth. So this all causes a negative impact, and thus they stop asking for help, clarifying needs, sharing experiences, and receiving health care. It is often hidden and attitudes are not challenged. So now the women should be encouraged to celebrate, keep a diary of positives, challenge the negative thoughts, make time to laugh. Humor can help with tension, stimulate immune systems, help in coping and enhance memory, learning, and women feel connected. Connect. Support of others who have been through similar experiences, such as women in support group or menopause cafe. The menopause cafes nowadays are quite prevalent in Western cultures, not very prevalent here, but India is recently starting to start this menopausal cafe culture. There is also one online menopause cafe, if someone wants to know. So where the woman, I think most of the women here do kitty parties, which is very similar to that. You know, menopause. My grandmother does some bishi, which is all old age women gathering and just talking. So that helps always because it helps you. You get to know about the experiences of other women going through the same phase as you. So challenge the normal way, and challenge the normal and the way menopause women are treated in society and in the workplace. Always you can make diet and lifestyle changes. We can reduce caffeine as well as alcohol, smoking, food diary for flush triggers. To manage night sweats, keep a cool glass of water nearby, keep the room like slightly cool. Calcium, vitamin D can help with bone health as well as mental health. Diet rich in fiber and whole grain foods, maintain a healthy body weight. Avoid hot drinks before bedtime and keep alcohol to a minimum because it can trigger flushes. Exercise can be very beneficial as well. Yoga at night or during the day improves sleep. Weight bearing exercises like walking, running maintain bone health and are also excellent treatment for mostly all psychiatric symptoms as well. Generally for hot flashes, SSRIs, SNRIs can be prescribed. Paroxetine seems to be most effective. Venlafaxine is also used by a lot of patients. Gabapentin helps with flushes and sweats, help with sleep and joint pains. Clonidine is also used for hot flushes as well as HRT, we all know that. The prescribed alternatives only work on vasomotor symptoms and on mood and do not have an impact on other symptoms or protect bones or heart. And it's not the first line treatment and only used in women who cannot take HRT. So we did not change as we grew older. We just became more clearly ourselves. Thank you.
Thank you, Dr. Aditya.